Thank you, Eileen. And now it's my pleasure to introduce Beth Burrough. She will speak on the topic of perspectives from a home service sector, specifically mom's meals. Beth is a partner of Healthcare Alliances and Chief Marketing Officer for Pure Foods. Beth, welcome to the podium.
Hi, thank you. And I want to thank the committee for inviting us. It is really an honor to be able to come in and talk to you and create and collaborate on what we can do to better deliver solutions to the aging and the vulnerable. I am there. So today we were asked to describe how we actually get nutrition to the aging and vulnerable. And I want to also talk about some opportunities, and I'll really focus in on our customers because I think it's important to understand who they really are just beyond the numbers. So as background, our company's name is Pure Foods, but we're actually market our product under the name Mom's Meal Nourishcare. And we're a provider of fresh-made meals across the country to all 48 states. And it was started by two families, my family and actually the Andersons, and Mike Anderson is here with me in the audience today. And it was 15 years ago when we were thinking about some of the issues facing our own parents and friends' parents, and started on this mission just in Iowa with one agency. It's now grown to over 14 million meals a year, and 250 partnerships with state, local, government agencies, and health providers. And our real focus is that rapid delivery of meals to any patient, senior, or disabled person in the nation with these meal profiles. And our mission is really to be that leading expert and provider of aging, disabled, and patient nutrition that helps them preserve health, combat chronic disease, and live independently and nourishing their independence. And Lisa, when she started the session yesterday, talked about how important that independence is to preserving their dignity as well as successful aging. Here's all the things we're going to do. In 20 minutes, I don't think I'll ever be able to describe the complexity behind it, but I want to focus on the center circle where we talk about providing a custom solution. And this is really a solution that is created and controlled by our customer. And I think that's a critical variable in that they are not being told what to eat, they are actually designing what they want and how they want to receive it. And it's for their acute and chronic care needs. And in that, I do include those who are malnourished as well as those who are food insecure, because as we heard yesterday, those are really health conditions. And one key important variable in that is the variety and choice that we offer individuals. And we'll talk about how we can gear that to their needed medical needs, but more importantly, the fact that they can choose and they can actually control what they eat helps with compliance and also helps with just their satisfaction with the program. So who do we serve? We serve the aging disabled I've talked about, and with these different programs that were well described yesterday, and then also patients and their caregivers. And it's just, that's more of an emerging area with Medicare. I was talking to Gordon in the lunch line a little bit about the opportunity in care transitions. There is considerable opportunity, and we're going to talk about what the research needs there are. And the reasons the plans are currently reimbursing, on the Medicaid side, it is this nursing home diversion, allowing people to age in their home, not have to go to an institution, which is obviously much more successful in terms of their definition of how they want to age. And then on the Medicare side, there's this opportunity in care transitions and chronic care management. And I brought up yesterday in chronic care management, there is a pilot coming with CMS. I think it's critical that this group ensure that we're part of that pilot because chronic care is a huge health issue, and without nutrition management, I don't see how that can change. I want to go a little more in depth in our customer because I think if you really appreciate beyond the numbers, who we're dealing with and how sensitive their needs are. And when you look at the Medicaid waiver program, it's really meeting those individuals who qualify are actually those who would otherwise be going into nursing homes. They have 90% activities of daily living limits. They age in the Medicaid program anywhere from 2 to 112 years, but our average age is 68. And they're below the federal poverty level, but I really want to focus on this chronic illness is 80 to 90% within the 65 plus category. And so we're really working on individuals who are sick and who have health issues. To dimensionalize this a little bit more, the top letter there is from an individual who is malnourished, weighing 107 pounds, and after receiving our meals, got her weight up to 135 pounds, which was critical for her own health. But we also have individuals with multi-medical issues, such as 2 strokes and stage 3 renal failure. And here's her daughter who doesn't know what to feed her with those medical issues. And another individual who has arthritis and is unable to function successfully, and so as a result is going to eat fast foods. They can't cook their own meals, and they then are contributing to their own health issue, and they're cognizant of that, but don't have another choice. And finally, here's an individual who is disabled and said they could eat our meals all the time. And if you go further down in that letter, being on a fixed income, it sure would be expensive for him. And that is really the reality of some of our customers. They have to decide, are they going to feed themselves, pay their rent, buy their medications, and yet the programs are only affording 1 to 2 meals, which is certainly a help. But some of these individuals could use all 3. So what do we serve them? We serve them 1/3 DRI meals, and that was talked about in length yesterday, but there are DRIs for different age and individuals. We focus on the males 70 years plus because that seems to encompass the bulk of where we focus. And the calories are dictated either by the state, or our default is the dietary guidelines for Americans. Again, as we talked yesterday, that's really a focus on healthy Americans. Who we're serving are more chronically ill Americans. The macro and micronutrients, the protein, the carbohydrates, the vitamins, they vary by DRI and state. And as a result of that, we have to manage 17 different nutritional profiles for 31 states. And you can imagine that's a level of complexity to try to do that within a manageable number of meals. And our dietitians are always struggling as to, are these the right nutritionals for the population we're serving? On top of doing those different nutritional profiles for the states, we also have had to develop 9 health condition menus for the healthcare partners with whom we partner. Their focus is less so on just making sure there's enough calories and more so on how do they address the chronically ill patients they serve, their patient outcomes, and how do they improve those. And so for guidelines for those, we've looked to the American Heart, American Diabetes, and other industry association leaders. So here's the type of meals we serve, and I think you're gonna see it is really healthy comfort foods. And Julie spoke to this yesterday. People like to eat what they like to eat. What we found is we were being pushed by some health plan partners to think about kale and quinoa. That didn't go over so well with our population. And so these individuals have formed their preferences early in life, and we continually survey our customers. It comes back to these healthy comfort foods, and that's what they like to eat. And that can also meet their health goals, fortunately. So meeting all these objectives across the clients, the states, is very challenging. We have these 25 nutritional profiles, plus we have to think about cultural, ethnic, and taste preferences in order to gain compliance. Try making a low-sodium diet taste good. That is not, when people are used to putting a lot of salt on their meals, not an easy thing. And the DRI was designed for healthy adults, but yet 90% of our population has 1 or more chronic conditions. And beyond all this, beyond the nutritional profiles, is a level of food quality and safety we have to have, and that has been elevated by our partnerships further with the health plans. So how does our program work? And this makes it look really easy in 5 steps. There are 600 people behind this making this really work to a level that it has to. First, in terms of enrollment, before that happens, before we enroll a patient or an individual on a Medicaid program, we first have to be approved by the state to provide to that plan. And additionally, then we go agency by agency, caseworker by caseworker, letting them know about our program. And separately with a health plan, similarly, there's a long process for contracting. It can take anywhere from 6 months to 2 years. Once we do form that contract, they will forward the clients or customers to our intake department where they're enrolled in the program. And we were talking with Susan briefly. She had some initial experience in this. It's a fairly complex enrollment, but once they are in, we call them and we ask them, what would you like to eat? Do you have any food that you don't like? And they will tell us specifically what they like. And then we have individuals who actually individually pack and pick meals to customize that order. We then call them and let them know when the meals are coming. They're delivered to their home, and we have to, from our own kitchens to their homes, keep that food under 41 degrees to keep it safe and fresh to eat to their door. They put it in the refrigerator where it stays fresh for up to 2 weeks. They can heat, eat, and enjoy it in 2 minutes out of the refrigerator into the microwave, from their microwave. And then we repeat the process because those who are on our Medicaid waiver program stay with us on average 18 months, and that's until they either unfortunately have to go into a nursing home or pass away. So how do we reach them? The logistics is something that is extremely complex, and I know that it was talked about a little bit yesterday in terms of looking at other ways, even using the post office. But what we do is use a combination of both our own mom's meal delivery trucks and UPS and FedEx. And we are able to get to any rural, remote, or even food desert within 1 to 3 days of the order shipping. And even to Rio Grande, Texas. I know Joe Sharkey's not here, but we even deliver to that population. And we take this very seriously. If we don't deliver the food, someone doesn't eat. So this is critical, and the degree to which we have to have compliance is basically changes someone's life. So, how do we do this? On average, the Medicaid waiver programs on average reimburse about at $7 a meal, plus or minus. With our healthcare partners, it's around the same. It depends on the level of additional service they require. But what I'm putting up here, I'm not going to take you through every one of these details, but it's not just a meal we're delivering. Behind that meal, you have all the case management and client services, the delivery to the door in a cooled cooler that keeps the food safe. We have a level of compliance and safety, and that goes a step higher when you have to add in HIPAA compliance for the healthcare plans. And then those healthcare plans are wanting reporting and utilization and other. So it's not, when you think about what has to happen behind that meal, it's a considerable effort. But it's worth it. And here's why it's worth it. These are the letters we actually get from our customers, how we can help them with their heart-healthy diet to help their heart disease, prevent malnourishment, and even on the bottom right there, we do get letters where our customers feel we have extended their loved one's life, even 2 years, to have a better quality of life, and that's why it's worth it. Further, how do we impact our clients' lives? This is a survey we did among 152 of our Medicaid waiver clients, and 91% of those clients felt that their quality of life had improved, and how that had improved was 75 felt that they were actually eating better and eating the proper nutrition they might not have otherwise done, and I can tell you that's because if you make it easy and convenient, and that's what's in the fridge, that's what they'll reach for. And then 40% reported that meals help them remain in their home, and they also talk about not having to rely on caregivers. And I think the quote at the bottom here, "I don't have to depend on anyone, it makes me feel like a human being," cannot be underestimated. In order for anyone to be self-sufficient and independent, that for them is a quality of life. So where are the opportunities? We've talked both days about the need for scientific research. There's a fair amount of research on malnutrition and its prevalence and impact. There's been very little research on the long-term nutritional interventions that are quality of life, rate of hospitalization, readmissions. And as we started to partner with health plans, this was more in demand. So we actually did partner, and Roseanne referred to this trial yesterday, the Gourmet HF trial, that we're partnering with the University of Michigan and Columbia Presbyterian. And NIH actually came in and added funding and sees this as a huge opportunity and interest area. So there is interest in gaining more research and knowledge. Additionally, we are partnering with Kaiser on, they continue to assess this area in terms of what high-risk populations would be best served. And then finally, in terms of the opportunities, rethinking nutrition, not just as a support service, which is really how it's been bucketed in the Medicaid waiver program, but as a critical health intervention. And it really has to be part of the medical plan, not the aside. And it is preventing nursing home care, it is post-discharge recovery, chronic care management. If you think about diabetes, renal disease, kidney disease, and obesity, those are all, the causes of those are nutrition related and can be addressed nutritionally. And thinking about redefining the DRI MEGA guidelines or adding therapeutic guidelines to really address the population we're serving, which is chronically ill. So I can't believe someone hasn't used the food for thought yet, but I had to do it. And it really is meals that address a patient's medical conditions can be an important intervention to prevent, slow the progression, and address the causes of those diseases. And at an approximate $7 for a condition-specific meal, that compares very favorably versus other interventions, even certain medical interventions, at actually getting at the root of disease. And there is no reason, if we're addressing this healthcare burden in the United States, why we should not be including nutrition in every one of those medical plans. And I just wanted to share with you, how important this is to our customers' lives and how thankful they are that they draw us, they send us oil painting and they write us poems. And so I think that just signals why we need to do more of this, because it really matters to them. Thank you.